Welcome to the Alex Salmond Show, where we give you the opportunity to question world-ranking experts on the COVID pandemic. With COVID resurgent across the UK and in many countries around the world, our three wise men answer your questions on what, if anything, can be done. From the world of intensive care, Professor Hugh Montgomery, Chair of University College London Intensive Care Unit, can advise on how treatments are progressing for the deadly condition. From the world of virology, Cambridge University's Dr. Chris Smith can tell us how close we are to securing a vaccine to offer an escape route out of this nightmare. And from the world of public health, Professor Harry Burns, the new president of the BMA and former Chief Medical Officer of Scotland, discusses with Alex whether the virus can be brought back under control through tighter public health measures. From your questions, we will seek to draw the lessons across the UK and internationally. But first, let's look at the reviews of last week's show on renowned Scottish artist Gerard M. Burns. And first we hear from Lynn Finlayson, who says, "Fascinating programme, what a fantastic artist Gerard is. Great to hear about our Scottish talent. Hope you make more like this, especially independent supporting artists." Anne says, "Love the interview with Gerard Burns, he's a great artist." Alan McCarg says, "Great show, thank you, Sarah Alba." Ruth Laird says, "Thoroughly enjoyed the programme, could have watched it longer, thank you." Faye Kennedy says, "Nothing more poignant than the flag and a bairn. That's what we're all about." And finally, Winnie Greer says, "About Gerard's paintings, I love the Saltire." Now over to Alex with your questions to our three top experts.
So welcome Dr. Chris Smith and Professor Hugh Montgomery. Now, our first segment of viewers' questions is on vaccines. I think particularly with the news of further restrictions in the UK, the virus resurgent in many countries around the world, people are turning their minds to vaccines. And the Chief Medical Officer in England said 6 months was an estimate. And we've got direct questions from Finlay Burns and from Maggie Chetty, who say, when do you think a COVID-19 vaccine will be available? So over to you, Chris Smith.
I was speaking this week with one of Cambridge University's foremost experts on this, Gordon Dugan, who is a vaccinologist, is an award-winning vaccinologist, and he has brought to the clinical coalface a number of vaccines over the course of his career. And I asked him this very question last week and said, with a fair wind behind it, what's his most optimistic projection? He said to me he's thinking realistically probably in 2021 June, so it might be as long as 9 months to go yet. The government themselves have said that we might see some vaccine available before Christmas on a small-scale basis. This might be just part of a trial or whatever, but really to scale this up, to get it to the number of people who need it and do it in a safe way, it's still going to take quite a bit of time. So that's why I think the projection of June 2021 is not unreasonable.
Professor Hugh Montgomery, Laura Connaughty and Vanna have written in questions about vaccine, but asking, in the case of Laura, there are 450 people dying from cancer each day prior to the pandemic. What are the predictions for mortality with a lack of screening and the inability to pursue treatment as you would normally do? And Vanna asks, how long is the process of strain mutation in a virus of this kind, and what implications does that have for a vaccine? So how does the balance with the treatments that are normally available in the NHS with the concentration on finding a vaccine solution to this pandemic?
Well, taking that first question more broadly then, there's no question at all that we are definitely seeing the health impact more broadly of the lockdown in treating COVID. And I was speaking with my colleagues only recently. We're seeing people presenting to emergency departments now with disseminated cancers that perhaps would have been treatable or curable if picked up 7 months ago, because they've not been able to see their doctors and they've not been able to get into hospitals for assessment. And another colleague in palliative care says the same thing, that they're getting overwhelmed with palliation now of people who otherwise might have been treatable. So it's a good point. We must remember that whilst we are all trying to save the lives of COVID patients, there really is a genuine big impact going on in the general population with diseases such as cancer that are not getting treated. That is a balance that we do have to address. On the issue of the mutation, viruses all mutate. In fact, all genomes mutate. We know that there are vast numbers of minor variations in this virus already. The one that was most dominant was known as a GD change. It's one amino acid in the spike protein, the protein uses to attach to cells. And the one that's now dominant is not the one that came originally out of Wuhan. It seems as if this G variant is a little bit more infectious. It gave it just enough of an edge to become the dominant form. So my guess is, yes, it will mutate. It will change in infectivity, possibly in its severity over time. It's hard to know at what point and if and when that just changes the efficacy of a vaccine.
And Christopher, Peter Bota, emailing in from South Africa, he asked that direct question: what is the rate of COVID-19 mutations with other viral strains in the wild? We have, for example, the French and the Wuhan strains. Should we be watching mutation rate closer in order to predict new viral activity? How long, therefore, would a vaccine remain effective? What's your answer to Peter?
Actually, the biggest fly in the ointment is the fact that we don't make very long-term immunity to coronaviruses. If we compare this new coronavirus to the existing coronaviruses that just naturally circulate in humans, there are 4 other coronaviruses that just cause cold-like symptoms, but one of them infects our cells in a very similar way to the new coronavirus. So we can use that as something like a proxy marker for what's likely to be the case with this new virus. What we can do is, knowing that these viruses might not drive very powerful immune response when you catch them, we can make sure our vaccines do. And there are various ways to do that by adding chemicals called adjuvants to the vaccine that give your immune system a kick up the backside so that you make a more profound response than the natural infection does, hopefully conferring longer-term protection. But at the moment, we just don't know.
Well, that brings us neatly on to the questions of treatment, because Pilar Fernandez, writing in from Spain, says, why are most of the efforts and the mainstream media coverage, she says, are focused on finding a vaccine, while we don't know anything or very little about other treatments and medicines? Any chance of finding an effective treatment soon? So, Hugh Montgomery, what have been the advances in treating this virus in the last 6 months or so?
There is good news on the treatment front, and it's a good news story that comes worldwide, but also particularly from Great Britain, where our National Health Service is very well integrated, has a fantastic leadership in research, and it allowed us to do some trials very quickly and very effectively with great power to try to find things that worked. The first of those, actually, that really was much more generic around the world, is we realised a lot of the severity of illness and the sudden deaths we saw in hospital were relating to blood clots. That wasn't something we needed a trial for. We identified it very quickly. And patients now who are admitted to hospital will now be given much higher doses of blood thinning agents than they were before. And now the patients we're seeing in hospital all get that routinely, and we're picking up clots much, much earlier. And that in itself is going to make a big difference. The second 2 studies out of Great Britain, we had 2, one called Recovery and one called REMAP-CAP, and they identified the same signal, that low doses of steroids, which are anti-inflammatory drugs and are very, very cheap, make a very big difference. They reduce death rates and intensive care admissions by around 30%. And in medicine, that is a really, really big effect of any drug. This is cheap, very safe to give, and highly effective. And finally, there was a study out of the United States with a drug called remdesivir. That shortens symptoms perhaps by a little over 4 days. We don't have a really strong signal for mortality, but in the NHS at the moment, most patients who are severely ill are getting both a steroid, dexamethasone or hydrocortisone, plus remdesivir. And I think that with the anticoagulation will make a difference. Now, those platforms are still running. In Britain, we fortunately had a big drop in admissions. And actually, though, the downside to that has been we haven't had enough patients to be able to start expanding our knowledge of what's effective. But numbers are going back up again, and those trials are still recruiting. And there are other trials ongoing around the world, I think, that will produce new treatments. So it's a good news story in many ways. We've got some big wins already, and I think there will be more coming as these other trials, particularly abroad, where there are large case numbers, start reporting.
So down to the big question here then, Hugh, if you were unlucky, unfortunate enough to catch COVID now in September 2020, as your chances of surviving it, if you go into hospital, much better than they were in February or March?
We don't know, but I think that would be the case. We certainly saw a signal over time during the first COVID wave that intensive care mortality fell as time progressed. Now, that might partly have been organisational, because we were swamped at the beginning, and that was very difficult to manage just organisationally. But actually, we did learn a lot about, for instance, the use of anticoagulation, which I'm absolutely certain did make a difference. So yes, I think from the trial data from the steroids too, there will be a much greater chance of surviving if one's admitted acutely ill to hospital or to an intensive care unit. But just for clarity, that is not what is driving the reportedly, quotes, low mortality rate for COVID case at the moment. This isn't because we're better at treating it. This is largely because we're testing a lot of people who are affected are much lower risk groups.
Chris Smith?
Regarding the tension between drug treatments and vaccines, the other thing to bear in mind here is that prevention is always better than cure. And what a vaccine offers us is the ability to defend ourselves not just today, not tomorrow, not next year, but for years to come. And as the World Health Organization have pointed out many times, this problem is not going away anytime soon. There's at least 5 years of the present predicament to run, and thereafter we fully anticipate this new coronavirus is going to settle down and become an endemic human infection. It's going to continue to circulate, joining the other cadre of coronaviruses that cause seasonal infections in humans. And therefore, it's likely we are going to need to prevent this sort of infection, or at least the severe manifestations of it, in at least a susceptible population all over the world in years to come. And that means that having a vaccine that does that reliably and does that safely is a huge potential win and will enormously tip the balance in our favour in the future. And while acute drugs for managing the crisis here and now are very important, and lots of investments going into trying to find them, including cutting-edge AI technologies. I'm talking to colleagues who have got very clever ways of using artificial intelligence learning systems to look at how when viruses go into cells, they change the spectrum of genes that are turned on and turned off in a cell, and they can marry that pattern up with the changes that different drugs produce. And they're using the argument, well, if a drug produces the mirror image changes in the gene profile in a cell that the virus does, perhaps that drug could interact with that virus and stop it growing. So people are looking at enormous numbers of drugs that we already have on the shelves to see if they can see these sorts of matches. And that will help us here and now, but one must never take your eye off the longer term, because this problem is not going to go away, and therefore having a long-term solution that will work well before we get anyone in such extreme health conditions that they're going to need Hugh's help. Unfortunately for you, I'm not trying to do out business, Hugh, but that's going to be the really critical thing here, which is why investment in a vaccine is very important.
Join us after the break, where Alex asks our top experts what the future holds. When will this contagion finally be beaten? Join us then. Welcome back. Alex is in conversation with Professor Hugh Montgomery, Chair of the Intensive Care Unit at University College London, and Dr. Chris Smith, virologist at Cambridge University.
Now, we've had a number of questions about immunity, and Scott Hutton, he wanted to know how many people have been found to have a complete immunity to the disease.
So the complete immunity, don't know. We don't know what complete immunity would mean. I think immunity does exist, and as I say, it does exist, I'm quite certain, but to this, how complete it is and how long it lasts, I don't know. We do know that the coronavirus does mount a significant immune response. Your body does defend itself, and it does that in a couple of ways. It makes these chemicals called antibodies, which are proteins that latch onto the viral cell and help your body attack that cell. So if you wanted my guess is that you do get some degree of effective immunity, but quite at what level of antibodies you need and how long immunity will last, I don't know.
Now, Chris Smith, JT asks just a direct question that Hugh's been alluding to. After contracting COVID-19, are we immune to the disease? Lots of people want to know the answer to that question. If you get it once, can you get it again? You alluded to that earlier, but you also said this disease could be endemic in the population. What did you mean by that?
We don't know what proportion of people will have long-term immunity having had natural infection with this coronavirus. And as we are beginning to see, alarmingly, there are people who were sufficiently ill with it the first time round to take them off to hospital. They recovered, but then they have been confirmed as catching it again. And it's not just that the virus lurked in their body. We can prove genetically that they've been infected with a new strain of the virus or a new variant of the virus, proving that the immunity that you make, at least in some people, is short-lived. Now, on the subject of pandemics versus epidemics, and so at the moment this is a pandemic. It came from one corner of China, as far as we know, It has eclipsed the entire world, and now we're dealing with it. But will it switch to become an endemic infection? We think it probably will. Endemic means it's effectively tied up, bound up, and circulating relentlessly within a population. Yes, we think that's the case. Other good examples of this: HIV has caused a pandemic. It came from one corner of Africa, it spread to involve the entire world. It's now endemic in the human race. So that's a good example of a pandemic virus that was a newly emerging infection that then's become an endemic infection, an endemic, relentless problem in the human race.
So one last question for you both. I'll start with you, Hugh Montgomery. In this great struggle that we're now immersed in between the virus on the one hand and science and medicine on the other, who's going to come out on top?
We've got to remember that we've had 3 emergent diseases in only 17 years, partly due to the way we treat our natural environments and animal husbandry and so forth. This won't be the last. Unless we start changing the way we behave, there will be more of these, and we'll go round this circle again. So it's a call to arms, echoing what Chris said earlier on: prevention. You know, an ounce of prevention is worth a pound of cure. Let's not take our eye off the ball. Let's start changing the way we treat our natural environment to try to stop these emergent diseases becoming quite so frequent and prevalent, because 3 in 17 years is quite a lot.
Dr. Chris Smith?
Really, the take-home message is, if we want to prevent this again, we have to look beyond just how we cure the present problem, but what the mechanism is of the present problem. And the mechanism, unfortunately, is it's our fault, and it is not a coincidence that these diseases are emerging from areas where there have been big population explosions. History keeps repeating itself. We saw the same thing happen with Ebola. The Ebola outbreak of 2013-14, that occurred in parts of Africa where there had been a 500% increase in population. So our target is to look at sustainability. We absolutely have to look at making sure we exist sustainably and we have more respect for the natural world and the animals in it to avoid these kind of jumps in future, because otherwise it's absolutely certain the viruses will win.
Dr. Chris Smith, Professor Hugh Montgomery, thank you so much for sharing your knowledge and answering our viewers' questions. Thank you.
Thank you.
With the search for a vaccine still ongoing and treatment still developing, it is public health initiatives which have taken the strain of virus control. Alex asked the new president of the British Medical Association, Professor Harry Burns, whether renewed clampdown can hold the virus at bay and why some countries have succeeded and why some are failing.
So I'm now joined from his home in Barrhead near Glasgow by Professor Harry Burns, the newly elected president of the British Medical Association. Many congratulations, Harry.
Thank you very much.
Now, if I kick off our first question from Lily, she says, how long can an asymptomatic carrier carry and spread this virus? Is that one of the big challenges with controlling COVID?
It's certainly part of the pattern of spread of the virus. The 14-day limit, I think, is probably not, by definition, no one knows. If someone is asymptomatic and they're walking about and they're never tested, you don't know if they've been spreading the virus. But the wise counsel is, if you've been close to someone who definitely has the virus, a positive test, self-isolate for 2 weeks, and you're less likely to be spreading anything after that.
Now, Tanis Gall, thinking about Scotland and specifically, he says, how can we deal with COVID if we can't control our borders? Doesn't that mean continual cross-infection?
Yeah, that's an issue that I've heard a number of debates about. I've heard a number of public health colleagues say that we really needed to shut down the borders, stop people from coming in, and others saying that that's a relatively minor contributor to the spread. We've got enough infectious people within our borders just now to be, and the way in which they're behaving in terms of not socially distancing and going to the pub and all that kind of thing, that's what's driving the increase in cases at the moment. So yes, it is an issue, but it's probably not the prime issue that's driving the increase in the number of cases just now. It's spread within social settings.
Now, Linda Mackay says, and she's very suspicious, she says, considering the history of mankind, masses have always been controlling them, the main ambition of world leaders. Is it possible that history is repeating in a sophisticated, modern way to stamp more control over all mankind? Are Lily's suspicions justified, Harry?
I don't think so. Not unless we've got pangolins as being agents of a foreign government or whatever. One of the things that needs to come out of this is rolling back the destruction of natural habitats. The climate emergency is a really serious public health issue for certainly my children and my grandchildren's generation. So, no, this isn't a fiendish plot by evil foreign governments, not even the Westminster government, but it has been a natural occurrence that you would expect when you're beginning to see change in the way nature or the human interaction with nature is occurring.
On our viewers' questions, a very poignant one from Louise Hogg. She says mass contact tracing, hand washing can continue, but with an average nursing home stay currently lasting 2 years, why would the elderly choose the existence of a hermit for their final years? What about this trade-off between the quality of life and the risk of catching this virus for the elderly?
I have a huge amount of sympathy with that question. But the fact is, the more people we allow in and out of nursing homes, the more likely everyone is to be infected. The deaths of patients in nursing homes, it was originally suggested in the Scottish Parliament that these deaths were due to people with coronavirus being sent to those nursing homes from acute hospitals. In fact, the data I've seen would suggest that it was mainly infected staff that were responsible for the transmission in nursing homes. So the fact is that anyone going in or out of these nursing homes is liable to be a carrier. And then it will spread like wildfire. And lots of people, some who are not seeing their relatives, are going to die. So we've got to be very careful about nursing homes, and we need to continue to be that.
Harry Burns, there is nobody more experienced in public health around the world than yourself. Is it really possible to control a highly infectious virus with the pubs open? Haven't the governments been kidding us by suggesting that was possible?
When we went down from 2 meters distancing to 1 meter distancing, I heard a behavioral scientist say, in your head, 2 meters is a distance, but 1 meter is just like reaching out and touching someone. And we see this. I mean, I have not been in a pub this year, and I've got no intentions of going into one. But when you see people sitting outside, tables of 4, they're leaning forward, their heads are close together, they're breathing droplets over each other. And I just don't think it is possible to control the virus while that is taking place. The evidence is that in health board areas that have had some lockdown over the past few weeks, the evidence is that the rate of transmission is slowing there. So the fact that we've been limited to the number of people you can have in your house and meetings and outside and so on is having an effect, but it's probably not having an effect fast enough. So whatever is announced, I think we're going to have to maybe not completely shut pubs, but we're really going to have people behaving very differently.
And can public health measures get this virus back under control? And doesn't the messaging have to be crystal clear?
Yes. So the messaging has to be 2 things. It has to be very clear, but it has to be very positive. You know, telling people that they are irresponsible idiots and so on is not a good way of persuading them to do it. But the messaging that we had initially, which was behave in this way, and you will be a good citizen helping out other people. It's that kind of positivity. We're all in this together, that having raves, that having long nights in the pub, staggering home and so on, is not helping your granny, it's not helping your fellow students, it's not helping your mum and dad at home. If anything, it's going to kill them. And we are already beginning to see increasing numbers of elderly people testing positive, which was what we predicted 3 or 4 weeks ago. So it has to be a message that says being a good citizen involves facts, doing what the government is telling you, and being sensible about it.
And finally, Sir Harry Burns, the looking at internationally, has there been one thing from a public health perspective of all the countries' experience that we've seen that stood out for you and you saw it and said, right, that's the way from a public health perspective to get this sort of virus under control?
New Zealand, no question. New Zealand, where the people grasped, so they have a government that was very honest with them and open with them to begin with. So I think New Zealand and one or two other places have been very successful in this, and it's all come from the fact that the people stood up and said, we're going to help each other out here.
Professor Harry Burns, newly elected President of the British Medical Association, thank you so much for joining me on the Alex Salmond Show.
It's my pleasure.
The virus is back. The UK threat level heightened, and few Western countries have been able to cope. Certainly not the UK, where lockdown 2 is now a very real possibility. Certainly not the US, where deaths per million have this week overtaken the UK. And certainly not in France, where the August holiday season has come with a very high COVID price. There are countries which have been islands of success, and many of them have indeed been islands. However, worldwide on current trends, by the end of this week, the mortality rate will approach 1 million. And by the end of this year, the international infection numbers will surpass 50 million people. Today, our three experts have given straight responses to some of the biggest questions and deployed them with profound common sense. Their comments on the connection between the threat of new emerging viruses and the destruction of the natural environment, and therefore the sustainability of the human condition, were particularly pertinent. Whether that can be translated into new and better policy direction remains to be seen. But for now, from Alex, myself and all at the show, stay safe, and we hope to see you all again next week.